Hi guys, welcome to another session. Today we're going to look at the drug Digoxin. We'll have a little look at its presentation and its mechanism of action. We'll have a look at some of the usages and side effects, a little bit on pharmacokinetics, and then a little bit on the management of digoxin toxicity / reversal of digoxin toxicity. If we start off with presentation, digoxin is a cardiac glycoside. It's extracted from the leaves of the foxglove plant, or Digitalis lanatus. It typically comes in oral tablets from 62.5 micrograms up to 250 micrograms. It comes in an elixir form, which is typically a 50 microgram per ml elixir, and it comes in a clear IV preparation with ampule sizes ranging from 100 to 250 micrograms per ml. When we think about the mechanism of action of digoxin, it can be considered as direct and indirect. The direct action is that it inhibits the cardiac sodium-potassium ATPases. What this does is it leads to an increase in intracellular sodium and a decrease in intracellular potassium. The intracellular sodium levels, as they start to rise, that leads to an exchange with extracellular calcium, and that leads to an intracellular calcium buildup. What that calcium does, it has a positive inotropic effect. It increases the excitation of the cell, and it can increase the force of contraction as well. This also has an effect by increasing the refractory period of the AV bundle and the bundle of His itself, or the AV node and the bundle of His. The indirect actions of digoxin typically work by enhancing the release of acetylcholine at the cardiac muscarinic receptors. What this does is it slows down conduction and further prolongs the refractory period of the AV node and in the bundle of His as well. When we think about this in the context of atrial fibrillation, in atrial fibrillation you have an atrial rate that is too high to allow one-to-one conduction of ventricular rhythm. So by slowing down conduction at the AV node, you allow the ventricular rate to be a little bit more responsive, and that allows a little bit more coronary blood flow, which allows the heart to pump a little bit better. When we think about the usages of digoxin, classically, as we've mentioned, it's used in the treatment of atrial fibrillation and flutter. It is historically also used in the treatment of heart failure, although that's falling out of favour. We have to be careful with people who have ventricular ectopics or ventricular tachycardia in using digoxin, because that can actually precipitate atrial fibrillation. When we're using digoxin, typically we start with a loading dose and then we switch them over to a maintenance dose once we've looked at the levels of digoxin within the bloodstream. When we think about the side effects of digoxin, what we have to think about is that there is potential for a variety of cardiac arrhythmias and conduction disorders. It can prolong your PR interval. It can cause some ST sloping, which there's an image of on the screen now. It's got a very narrow therapeutic index. It can cause nausea and vomiting. It can cause diarrhea and lethargy, and it can cause visual disturbance. And typically that's associated with a loss of the red-green colour field. It is also responsible for interaction with a variety of different drugs as well. When we think about pharmacokinetics, gut absorption is variable and oral bioavailability is around about 70%. It's 25% plasma protein bound, and there is minimal hepatic metabolism carried out on digoxin. The majority of the product is excreted renally with little effect on it overall. However, obviously, people who have renal failure, this can lead to accumulations of digoxin, and therefore we have to be cautious in those groups of individuals. When we think about toxicity, we can think about acute and chronic toxicity, although in terms of treatment they're relatively similar. Toxicity often is considered where the plasma concentration is greater than 2.5 micrograms per litre, and potentially fatal or life-threatening toxicity is greater than 20, but these numbers vary because it's a very unpredictable drug to measure. When we think about correcting or managing digoxin toxicity, we have to think about maintaining correction of electrolytes, as often associated with hyperkalemia or hypokalemia. Keeping the electrolytes balanced is key to ensuring no further excitation or overexcitation of the cardiac action potential. There is a specific antidote for digoxin. It's the digoxin specific fragment antibody, or Digifab. It's an IgG that has a higher affinity for binding digoxin than the natural digoxin receptors found within the heart. What this does is it binds and produces a complex which is then filtrated at the kidneys, making it essentially the remaining levels of digoxin inactive and then excreted.